So I'll invite the speakers to come to the front, and we'll promise you that we're going to have time for questions and answer. We'll skip the last, I have some small slides, but we can skip that. And we'll be ready for some hula dance by James Alice in 2:30. Thank you very much for your presentation. I have one quick question. This section was a lot about how to do things. And my first question is for the presenters here, actually, both of you, about how do you actually go about engaging or forming those non-healthcare sectors engagement and partnerships?
Sure. I mean, ours is maybe somewhat different in that we're also a funder. So we selected communities, but then we worked with communities as a partner. At least I hope they would say that. That's why there was a lot of back and forth between what are the right interventions, and that's why we kept asking the question when I talked about the dose concept. Can you reach more people? Can you have a stronger touch? But that was a conversation we had local evaluators working actually in the community, rolling up their sleeves, like at the planning meetings, checking in, and it was kind of on an ongoing basis. So it was ongoing conversations. But how do we get to the table? That was through money.
He who pays, he who saves.
Ours wasn't through money, but that sounds pretty good. So I've actually been working with this organization for almost 20 years now. And it began when most of my team had young children and kept talking about this wonderful organization and how they came into the home and helped you to deal with life and children. And I reached out to them because they didn't have any nutrition at all in their curriculum. All they did was I should say all they did, but they did child development, child welfare, and family strength. And reached out to them to ask if they would be interested in anything around child nutrition, parent modeling to nutrition. And that began this relationship that's gone on now for numerous grants, where we've looked at different aspects of parents and parental modeling to children, different behaviors, parent diet, activity, lifestyle change through preschoolers, through teen parents. We've done different sections with them. They're not the same organization they were 20 years ago. 20 years ago, when we began working with them, they didn't want any money at all for doing any kind of work with us. And now there's a whole different model. 20 years ago, there was different leadership. So I guess the point is the organizations change just as we do, and their mission changes. When the recession hit, they were just trying to survive, and that changed things. So there's a certain flexibility that goes back and forth, but I think the main thing was that they wanted what was best for their moms and kids and families, and if we could bring it to the table and be flexible about how we did it with them, they were willing to do that.
So, go ahead. So the next question is for Dr. Jernigan and Dr. Kalokula. It's acculturation is a two-way street and assimilation, and there are many years of market forces that have an impact on healthy ways of living. And how were you able to counteract those market forces to actually engage community with values that they had from many, many years?
Valerie, you want to?
Yes, aloha keave. I think that's always a really challenging question. In some Native communities I've worked in, and the studies show this, traditional foods and the gathering and hunting practices and fishing practices that accompany traditional foods are prioritized over other foods. And in some communities, the priority is quick, convenient, and low cost. And so it really varies across Native communities But one thing that I have seen in the Thrive study and in the other community work that we've done is that people do have a genuine knowledge to learn about their traditional cultural practices, and to keep learning about those things and to share that knowledge. And so when we often, couch interventions in a larger picture of, identity and Native identity and being part of the community and being part of the traditions that we've always had, that food is medicine and that our traditional practices are healthy. And that tends to bring people into interventions when they otherwise wouldn't necessarily come to, participate in something that had the word obesity in it or was focused on obesity. But they will come to a food sovereignty discussion. And so it's that kind of thing that, that we do. It's always about the larger story. It's about food, but it's not so much about food as it is about healing. And so that's kind of the way that we think about all of this work. It's all connected and it's all related to healing. And in whatever ways we can reach different populations and people within our populations, that's how we do it.
Thank you.
And to add to that, Carlos, is it's really changing a narrative for Indigenous people. Since the arrival of foreigners to our shores, the narrative has really been that of their perspective and their expectations of us. When Captain James Cook first arrived to Hawaii in 1770, he observed a very healthy, robust indigenous population, approaching 1 million in population size. In fact, he make note and his officers make note in their journals how impressed they were with the health status and the social aspects of Pacific life. But much have changed for us, and much have changed around the narratives. Many stereotypes, false stereotypes, negative stereotypes of our people have been internalized. And what we're trying to do is a cultural empowerment approach in which we're empowering people to say, hey, what you're hearing is not correct. It's really a different narrative. And what we really need to understand is that our people were once healthy people with healthy practices. We just lost those practices. We've adopted certain Western lifestyles such as fast food and processed foods. Our current economic situation drives us in a particular way that is unhealthy, not that we want to, but it pushes us there. We need to begin to understand that so people feel empowered and begin to shed those negative stereotypes and internalization of those stereotypes. I've been in clinics with physicians, shadowed them in the early days. Fortunately, it doesn't happen as much these days. But I've heard Native Hawaiians ask, why do I have diabetes? And one of the first things they say is, because you're Hawaiian and you're at risk. Well, and you're also asking them to make dietary and other changes. Well, they can't change being Hawaiian. And we know that now, better know that that is not true, that there are other reasons that they're at risk for diabetes. But this is the information they've been getting from healthcare providers and others and from the larger society that we need to change and empower them to make these changes.
Thank you. Thank you. So that concludes, are there any questions from the audience? Okay, that concludes session number 3. I want to thank the speakers. Great presentations. Thank you.